That's great. Okay, hi, it's great to be back in Toronto again. Even nicer now you've got some British weather. It's been just a tad too hot at the weekend. So, yeah, what I want to do is to really have a bit of a run through, think a bit about performance and quality, a little bit of a brief history around QOF, what has QOF achieved, and then start to question, well, why change? You know, what is it that's going on? What's the change? And something about the future direction of travel, maybe raise some questions. So I'm terrible, I talk too much, but I'll try and clatter through this so that, you know, I'll put a nice presentation together, then you can ask me all the difficult questions afterwards, the things you really wanted to know, but I didn't cover in the talk. So, I think we need to start with defining performance. I mean, QOF is a performance scheme. It's about measuring the performance of general practice in the UK. So, you know, what do we mean by that, and how's that linked to quality? Well, we can think about performance as the competence. So how well is that? What's the quality of the work that's done and how it's done, and what's the quality of the work that's produced? Now, they're quite interesting questions, obviously, and quite important questions. But the other thing is, well, who measures it? What are they measuring it for? What are they measuring? And why? I mean, they're also kind of the sub-questions that might come under it. And just leave one extra question about this notion of, can quality actually be measured? So there's an interesting notion. Hopefully, during this discussion, we can get to some of these points. So what do we mean by good performance? Well, you know, good performance, you think might be an obvious thing, but we can think about formal and informal performance. So formal performances are the kinds of activity, financial metrics, things you can actually get to grips with, and they've got lots of numbers that we can look at what's happening and look at trends. But actually, there's informal performance. Spent Saturday afternoon with Nusrat talking about informal performance. You know, what's reputation? Well, what's a measure of reputation, for example? And so these are very important things, and they often provide much richer insights, but they tend to lack consistency. So what one person thinks might be good, another person might not. And the question is, if we want to think about general practice, we can think about whose performance are we actually thinking about. So I'll be thinking about the individual practitioner, who's a good GP or who's a good nurse in terms of the way that they treat their patients. But what they do is also wrapped up in their team performance. So how does the team operate? Well, you know, what are the tensions in the way that people work together? And often as care becomes more complex, people need to work collectively together. So who is the person that puts in the performance that comes in the outcome? Quite interesting things. Then what about the whole organizational context? You know, how does the organization function? How does it support people? That also impacts on the performance of an individual person as well. What about patient? You know, actually, if you think about some of the things that get measured, to be honest, if the patient didn't do it right, then nobody would get their performance. A very good example is that GPs get rewarded for measuring blood sugar. Well, you know, anybody who's diabetic knows that actually it's a very individualized thing. Yeah, it's great to have support, but actually the person who gets the right readings for the blood pressure is the person who actually does the things that keeps their blood sugar under control. But we don't give them the money, we give it to the GP, of course, because, you know, that's what we do. So in the good old days, I mean, you know, I talk to GPs a lot, and there is this time of the good old days in general practice in the UK. For some people, that was kind of a few years ago. For some people, that's 20, 30 years ago, basically when the government left them alone, really. So general practices tend to be independent, self-regulated system, you know, through the General Medical Council. You know, basically, if you were a bit naughty or anything, then the General Medical Council, when you get reported, they might come along. But essentially, the doctors sorted themselves out and did. Quality was really focused on inputs. So that's the development of general practice training schemes, the development of continuing professional development, informal learning in groups, you know, talking to other GPs. On the whole, though, most GPs rarely actually talk to other GPs. It was a fairly kind of isolated business. In the 60s, saw a bit of oh, actually, you know, perhaps we ought to have good premises. If we want to work well, we need good premises. So there was something about putting the right kinds of buildings and premises. And the NHS administered the whole thing, gave the money, but basically left general practice alone. During the 80s, general practice came under the gaze of government for a number of reasons. I think recognition of increasing complexity of care, the acknowledgement actually that somehow general practice was the cornerstone of the British NHS. You would think, of course, having been like that since 1948, you wonder why it took them 40 years in the government to realise that general practice was quite important in the way that the system operated, rather than just the way that general practice or hospitals, but actually thinking about it from a system perspective. There was also an increasing awareness about variability between practices. You know, some practices did something, some practices had nurses, other people didn't have nurses, some practices did this and other practices did that. So there was a bit of a concern about variability. Practices were mainly treating people, and you know, maybe we ought to think about whether they should be doing a bit more prevention work. So in '87, the government introduced the first performance type system, which was basically a threshold payment. And it's a stage threshold. So for example, cervical smears, you know, if you've got 50%, you've got one payment. If you've got 70%, you've got another payment. If you've got 85%, you've got another payment. And what do we know about that? Well, we know that the practices that could just about get to 50 stopped at 50 and didn't do anything else. The practices that could get to 70 stopped at 70 and didn't do anything else. And the practices that got to 85 were doing it already, so they just got the money. So probably not a very good incentive scheme. And in fact, it did incentivize. It incentivized people to work to the threshold. Q ought to have been remembered, really, because in 2004, the government then extended this whole thing across the quality and outcomes framework. And it came at a point of change in general practice. I mean, essentially, really, it was all about money. I mean, let's get down to the nub of this. 2004 contract was all about increasing GPs' salaries or total income pot. There was some reticence to do that just by expanding the global sum. So they developed a scheme which had basically three elements to it, and about 20% of the sum was in something called the Quality and Outcomes Performance Framework. There was also some other stuff which was directed, whether it was for IT or premises or doing this or doing that. So there's some extra bits as well. Why was QOF put in? Well, Alan Milburn, who was the Minister of Health then, the Secretary of State for Health, was concerned about variability in practice at this point. How do we get some kind of standardisation of practice across the country? Something that we've kind of dogged not just UK health systems, but any health system you want to think about. But when you've got 10,000 or 11,000 practices, kind of variability is quite enormous, obviously. So the idea about the QOF was to introduce a scheme which would pay for particular areas of care. Now, so they developed a very complex system which was based around different parts of, so we had processings, we had some clinical outcome measures, and we had some things about patient response. So it's a kind of a mixed bag of different outcome and process. But actually most of the outcome ones were process as well, because it was things like blood pressure, you know, controlling blood pressure or measuring this or measuring that. So to think that they were specifically outcomes might be a little bit of a stretch too far. So how does QOF work? Well, practices get awarded points, and every point is worth money. So that's the basic thing. It's about high quality care delivered. The outcome suggesting quality care were delivered, you get the money. But what is high quality care? So we can think of all sorts of things that might be related to high quality care in general practice. So the question is, does QOF cover all of those? And the answer is probably no. In fact, the answer is no, it's not even probably. What it did do was this kind of thing. So here we have an example of some of the indicators. So percentage of people with dementia with a care plan that was reviewed in the last 12 months. You get 39 points for that, and that's then put across the population of the practice size and then generates a sum of money. If you get 70% of the practice achieving its threshold of expected numbers of people with dementia who ought to have a care plan, then you can do that. So mainly achieved, those sorts of things, so quite easily. And the same with stroke and that. You can see most of the achievements pretty close. The diabetes with the blood pressure is the only one that probably, but then it wasn't worth much money anyway, so people necessarily tried. But that's the whole system is structured like this. So it's structured around a particular threshold and then achievement values which are expected within a practice. So what did it do? What's QOF done? Well, first thing it did, it made practices employ a load of nurses, because nurses, and in particular not just nurses but healthcare assistants, because they can check blood pressures, they can check sugar levels, they can check, you don't need a GP to do half these things, so you employ a cheaper person to do all these things, and you develop clinics and you have this kind of process. And it's really important because every year there's a census date, and on the census date that everybody checks up, and if you meet the thresholds, you get the money. So definite incentive to do things like that. Promoted better IT. Basically the government said, you don't have to join this, you can join it, but if you join it, you've got to produce this kind of data for us. If you've got to produce that kind of data, everybody's got to have an IT system that speaks to each other as well. So we've got a standardised IT, better IT systems from it. Got brilliant record keeping, because if you've got bad record keeping, you don't get any money. So record keeping has gone up quite a lot, and transparency from that point of view. And as a result of that, in some ways, it has reduced variations amongst practices. Most practices now have much better disease registers than they had when the scheme started. So particularly the ones that didn't really know who all their diabetic patients were or who all their dementia patients were, they've managed to up the numbers. So they've got great disease registers now. So that is quite important, because if you're going to do practice, you need to know what your population is. So that's been an important issue that's done. And that levelling up has actually been important. But actually all we've done is reduced variation in reporting and practice registers. So, and if you look at the variation of scores, so in 2004 the variation was like that, and very quickly it narrowed to very little variation. And we keep tinkering with the edges, but everybody knows the system now, so the variation hasn't exploded again. It stayed at that very, very narrow between practices. So kind of think, well, what are we actually measuring in the system? So let's look at some examples. So here's an example of one of the things that happen, and I want to come back to this one. So every year, on the whole, for all ages, we have this blood pressure 150/90. So what can we tell about 150/90? Well, it's not the NICE guideline for blood pressure. It's an easier one to meet. Everybody under 150/90. But for 1 year, they did introduce, for patients under 80 years of age, 140/90 with a varied threshold payment. I want to come back to that. This is quite interesting when you see a new threshold introduced for 1 year. And we'll come back and look at the effect of that. What are some of the other things? Well, this is at the start of QOF. We can see that there is some improvement in incentivised measurement. There looks like a step for 2003-04 when the scheme was introduced. So you might want to conclude from that that everything was getting better because of QOF. But actually, if you look at some of the other incentivised and non-incentivised, you find that they were going up as well anyway. So what was QOF and what was general improvements in practice is actually quite difficult to discern. If we look at, people remember I've used this one a few years ago, but here, if you want to look at what the impact is on unplanned and planned admissions for the appropriate thing, yeah, there was some difference. Not much, but some difference. My only question is, that costs £2.5 billion. So you kind of got to think about whether that's value for money for some of these things, which I haven't mentioned yet. Let's get back to the blood pressure. Now, this is really interesting. So we talked about, I've said that QOF influenced, well, clearly practices to try and make sure they've got everything measured and into QOF to get their money. So that's great. So it's improving clinical care. People are getting the right blood pressure sorted out and recorded and all those things. So this is we did some work, colleague of mine, Matt Sutton, and colleagues at Manchester were looking at what happens when you take QOF indicators away. What's the impact? So we looked over time. Now remember, there was one new indicator in this year, 2013. So what we get is some slight improvement, step down. Some of the interesting thing, you're getting more and more missing readings over time. So that's people who've been excluded for one reason or another. So that's not good. But actually, what you also see over time is that BP of 150 over 90 improving gradually. So that's good. But this step is the bit that I'm particularly interested in. And PhD student at Manchester did some further analysis on this. And let's have a look at this. So this is actually, when you measure blood pressure in practice, these are the readings you get. Anybody want to notice anything odd about that? Seems to be a propensity to put 120, 130, 140. I mean, as a social scientist, I know that categorization is a great thing. It makes people behave in all sorts of ways. So normally, we've got recordings which are very odd. We don't have a nice, even, normal distribution. It has the semblance of a normal distribution, but it does have these very odd things. This is QOF reporting. Kind of looks a bit different. I think the 140 has kind of gone up a bit, particularly in 2013 and 14. What's going on here? I mean, this is clear. Let's look at that one in closer. So that's all the readings. Yes, of course, we have a spike at 140 over 90, as we do at 150 and 130. But when they introduced the QOF indicator, that's what happened to the 140 over 90 spike. So now, we've got to assume that people don't have blood pressure which fall very neatly into these categories. So what you're seeing here is an effect of translation of clinical practice into the record. So here we have a very clear example of one of the things that QOF, or these performance type measurements, do to the way that people conceptualize what it is they do. So they will take clinical readings and put them in a different way for various reasons. But there we go. So that might be reason enough to review QOF, but it wasn't. I think people kind of recognize some of these things. What actually came up is what we had in 2014, which is the 5-year forward view in the UK, which was where we're starting to think about moving to more integrated care, trying to get more money out of the government, which was Simon Stevens' plan. It was really about trying to get more holistic care in the system. We were going to have larger practices, integrated care. We're going to change the policy. We want to focus much more on long-term conditions, multi-morbidity, integrated care, patient-centered care. I mean, things we've talked about for donkey's years, really. But anyway, it's now kind of come up as formal practice. And we have the general practice forward view in particular, which was 2015, about investment in UK general practice, which I have to say probably up until last year had been falling, gradually falling, by comparison to all the other bits of the NHS. So is QOF fit for purpose? I shall avoid just saying no and do it properly. Right, so does the QOF promote progress towards the vision of the 5-year forward view? I.e., does it actually make people think about integrated care, holistic care, patient care? Does the QOF do what it was intended to do? So that's about variation in practice, about standardization. And does it support developments in primary care? So that shift away from the organizational ones to clinical ones, is that what we really want? QOF is about single disease, not about multimorbidity. It's not really about integration and coordination. It's certainly not about patient-centered holistic care. And it's not really about self-management because it doesn't reward those sorts of things going on. Has it standardized care? Well, everybody's pretty good at it. Okay, they can get, we're right up at the top level of the indicator board. But on the other hand, there's been some effect on in-between practice inequalities from that point of view. Not a huge amount. We don't have a lot of data to support that. Has slowed the increase in emergency admissions, but that could be due to other things. I mean, we don't know. I mean, you know, we know that there's been a slowing. They've just said that integrated care groups have slowed the admissions to A&E, but then, you know, some practices that aren't in integrated cares have actually got better reductions in admissions. So it's not, you know, what's what is an interesting thing. It has increased consultation rates around mental health issues, so that's a really positive thing. And it's also increased implementation of some of the kind of well-developed care processes for people with diabetes. I think people with diabetes, it has been, I would say it's been quite successful. We actually still don't know a lot about how practices work with diabetic patients, but on the whole, it's made better engagement. So that would be a plus. Has it improved processes and outcomes of care? Well, we're a bit short of evidence, really, particularly around integration and coordination, about what holistic self-care workload. There is some evidence that QOF doesn't really affect mortality. It's not really focused on the things that would probably do that. So kind of focusing on some of the outcomes. When you look at some of the RCTs, it does overestimate some of the effects which you would see in practice, so that's a problem. Misreporting by practices? Goodness me, of course not. But yeah, there's a lot of misreporting by practices. Some intentional, perhaps, and some maybe not less intentional, and some clearly mistakes. There's the limitation of the data as well. You know, what we looked at, when you look at it, you can only really study the outcomes from HES, so we don't have the data in the practices. The nice thing about the blood pressure one is it was taken from practice data, which meant, and we can still see the same problems. So I think, you know, if we see problems in the HES data, we can see it in practice data. I think we're fairly certain that the same problems exist. And clearly, because everybody's doing it, there's no way of controlling for some of the data as well. So has it motivated? Because that's what we're really on about. You know, what's QOF done about motivating primary care professionals to improve the care? That's one of the things that was thought it should do. So what motivates? Well, actually, you know, one of the problems is financial rewards. They are motivating, but other motivating. So we know that having more money makes people do things. That was the blood pressure one is a good example of that. So we do move it. But there is a sense that there's also a platform. Once people feel they're kind of comfortable with what they're doing, they don't then seek additional money just for the sake of it by distorting things. So that's a problem. There may be other more effective motivators. You know, some of the stuff around practice nurses we know is around the fact that they've developed some kind of autonomy in the practice, so it gives them a more robust job. So they actually quite like it. So what we've done is we've changed with QOF the way that practices work. And if you look at consultation rates, there's always been a gradual shift since the 70s from GPs to practice nurses. But you see really from 2004, the number of people who now see a practice nurse first has just mushroomed quite enormously. So we know that it has done that. And they can take on a lot of the routine tasks, and they can give a lot of the very routine tasks to the healthcare assistants. So that's actually made them feel they got a better job. So that's been quite interesting. GPs, there is a bit about practicing evidence-based care and trying to push them to focus on holistic care and the relationship with the patient. It does get kind of blunted some ways as GPs complain about IT systems which keep telling them to do things with patients which they didn't necessarily want to do. Because the way that QOF works is the practice manager who looks at things and thinks, I need to make sure we hit the thresholds, says to the IT manager, please, when the patient comes up, flash up a box to show them whether they've met. And that happens. So and that happens beyond the GP. So that's done through IT systems. So the way that the IT system affects the way that care is delivered in practice because of QOF. So we are changing practice around here. Does it motivate general practice? Well, we think it does. Motivated to keep practice income as high as possible because it's part of the contract. You know, it is part of the contract. It's actually worth less now than it used to be, but it's still part of the contract. It's still, and therefore it will be fiercely resisted in some ways if you try and change it, unless the government came along and said, well, that's all right, we'll just give you the money instead. And the government's too frightened to do that because they think that, so we're in a position here of contractual relations, you know, now interfering with what QOF does. And no, because really it doesn't deliver care that's not incentive. It doesn't seem to be a general effect in the literature. Doesn't tend to improve achievement over the highest threshold. So that goes back to what I was talking about in the 80s. We know that once people reach the threshold, it's not worth actually putting a lot of effort into probably the people that you need to see because they haven't come in. So that's a problem. And it doesn't tend to prioritize the most complex patients. In fact, if you've got a really complicated patient, you want to keep them out of the QOF system because they're not going to meet it. So you do something called an exception reporting to say that you can remove them out of the denominator, because that way you increase your income. GPs and practices are perfectly rational beings. You know, they are, you know, they are driven. So this is some work, in fact, that David and Nagina have been looking at. There's a wealth of kind of quantitative data about QOF, but there are some snatches of qualitative data, and Nagina and David have done a kind of good job of pulling out some of that qualitative data, and they're looking at the notion of values. Because actually, if you're thinking about motivation and behaviour, we're actually thinking about what is it that makes people do things. So we need to now understand what makes people do things if we want to put a performance system over the top of them. So we looked at the implementation of QOF. It emphasises some values, as we've just been looking at, certainly at the expense of others. It says that quality initiatives actually have to be compatible with the provider values. So you need to discern your provider values first and then work out what your system is for motivating that. And clearly, and this is true for probably anybody in this room, let alone GPs, we do things because we want to do them, as well as because of the things that people encourage us to do. And often what we try and do is limit the stuff that people outside are trying to encourage us to do so that we can carry on doing the things that we want to do. Surprise, surprise. GPs are just the same. Clinicians are guided by their views, beliefs, experiences, and not by the external influence. So these intrinsic values are far more probably important than extrinsic values. So if you don't line up your extrinsic with the intrinsic, Bob's not your uncle, shall I say. Okay, so are there alternatives to the problem with QOF? Well, if people stop at the threshold, why not make the threshold 100%? Well, they'll all give up. All right, there were some areas in the UK that tried this. Some bits were successful on the whole, because some of it gets very difficult at the end. All right, and you tend to increase your exception reporting, taking people out. So that's not what you really want to do. How about some better criteria based on health outcomes? The only thing that really is linked to mortality was actually dealing with people with epilepsy, with a paper that I did with an ex-student of mine a few years ago. So, you know, maybe, but health outcomes, linking practice to health outcomes, quite difficult. What we tend to have are interim, like blood pressure, rather than the actual dealing with the outcome itself. What about different kinds of financial incentives? Well, you know, could we actually say, okay, well, we'll contract with you to deliver this sort of care. You know, and if you deliver that sort of care, we'll give you 50% up front and 50% on completion. Or we could have outcome-based funding, which has become quite popular, but probably won't stand around for very long. You could have peer pressure. You could put money in a pot and say, there's a load of practices here, just make him do what or her do what, and you know, you do it for us, and then everybody gets some of the money. You know, but that's a bit of a problem, because if they don't do it, then you might penalise, you know, so peer pressure. Patient-reported outcome measures, there's probably some good benefit here, but, you know, it takes a heck of a lot of work just to produce the outcome measure. So, you know, what about what's needed to produce the outcome measure in terms of the investment that you want to make? So that may not work. What about paying for virtue? We just want GPs and nurses to do the right thing, really. So if we just pay them to do the right thing. So doing the right thing. So we could think about, do patients get access to your practice? If you can demonstrate that there's no barriers to access, you'll get a payment. Are you fairly equitous in the way things are happening? We could pay you if you've got, you know, so thinking about it. what's the measure of patient-doctor communication and how's that valued by patients? You could actually come up with some measures there. And there was a paper a few years ago which looked at something called payment for virtue. So dealing with the crane. So there's all kinds of examples. But actually, when we think about general practice and quality, let's go back to Starfield, because I think we need to actually conceptualize what we mean by quality. So we're back to the beginning question here. First person contact, yeah, that's clearly part of it. Person-focused care over time. So any system that's looking at one-off in a year payment may not be the right kind of system anyway, because actually what we're looking for is long-term continuity of care, not one-off things. Comprehensiveness, coordination. So you can wrap some of those things up into one word, which is continuity, you know, improving continuity. Things like communication, holistic care, awareness of the family's culture, all these sorts of things deal into that, and kind of improved satisfaction, health outcomes are associated with continuity of care, patient-centeredness, long appointments, good patient-doctor personal relationship, none of which are measured in QoF. Okay, so, you know, we actually have quite a good idea of what we mean by good quality primary care, but actually what we do is we measure the performance of other things, which we think does that. So what about investing in quality improvement? So what the NHS England have come up with is a new wheeze, and we're just doing the first year evaluation on this. They've put some quality improvement indicators in. So there's two areas. One is about prescribing safety, and that's for some very specific drugs that are prescribed in general practice. And the other one is about end-of-life care. And the idea is they'll change the topics every year, just like they used to change the QoF indicators, but the idea is to get practices to think about these things. And what they've got to do, the practice needs to identify the area for improvement. The practice needs to identify what it does. The practice then has to implement its quality improvement plan, and then it's actually got to go out and talk to other practices in the local area about what they're doing and how they measure up against other people. So kind of a collective part of it. To be honest, all they've got to do is tick 2 boxes on the QoF form to say they've done it. So I'm not quite sure, which is kind of probably why we're spending a year looking at what practices actually do. It's been quite interesting, just the first parts, that practices have actually engaged with this. They've actually talked about it in the practices. And all right, this is anecdotal because it's only a few practices that I've spoken to. We're just about to go and talk to 40 practices now. So it obviously has done something. But then you would expect that, because if someone gives you 74 points, which is worth a heck of a lot of money, then you're going to at least engage with it, you know, but the thing is, what is it that they do for that engagement? I mean, that's the thing we don't know. And they've also tried to stop people accepting all the kind of very difficult patients. So they're trying to disaggregate the people like me who just refuse to go and have an asthma check every year from the people that are more complex and kind of just, you know, they can't get to and should have an asthma check. So they're looking at it over the whole year. So if people have been sent letters and reminders, then they can be exception, but people who should be in there can't be exception reported, which is probably a much better way of doing it. And they're going to keep reviewing, they keep changing all the indicators as well. So they're not dropping the clinical indicators, but this is a change in the emphasis in the system, which does seem to have generated a bit of interest in practices. But there are lots of other things going on in the UK. Well, in England, actually, I shouldn't just say the UK or some things. So there's 3 broad things here. So we've got changing patient needs, you know, increasing levels of multimorbidity, so chronic care. We've got changing workforce. We've got a broadening of the skill base, integrated care, different kinds of workers coming into practice, shifting roles, interprofessional working, all kinds of things around the workforce, partly driven by some of those external things, whether policy developments or changing patient needs, partly driven by actually what is probably still a crisis in British general practice about recruitment, about getting enough people. We've got early retirement. They just had to adjust the pension rules because they changed the pensions rules, and GPs said, oh, I'm not working anymore because I'll break the pension tax limit. So there's all kinds of things going on in general practice. But we are short of GPs, we are short of nurses, and we've got an older GP population and an older nurse population. So, the crisis will carry on. And against the target of 5,000 doctors, we've managed to get about 3,000. So, it's a real problem. And that actually pushes practices to also want to change the way that they work, because they're working in ever tightening resource groupings. So one of the things they've been doing is kind of work at scale. We did a piece of work, it's about to be published in BMJ, looking at primary care at scale. Everybody's interested in primary care at scale. It's the big thing. We need to have bigger practices so that bigger practices can do better things. That's the general rule. So what we tried to do was work out what was happening in the UK. It's very difficult, really difficult. You've got a database of, well, in fact, there's 7,700, but we were looking at those with sufficient population. And it's a right mess. So you can work your way down the thing. We were looking for large practices, working as a large practice. That's what we were looking for. So we can kind of take out some practices with no data at all. So that was 3 million patients. Then we separated out the single practices which had more than 30,000 patients. So there's 1.5 million patients in that group. There were 4,000 odd which were working with other practices, i.e. they weren't one practice, but they've said they were working with other practices, and they all had a large group. And then there were lots of practices that weren't working with other practices, and they're the smaller group. So we stuck with these two, and then we tried to break those down. And then we got to the bottom, take out university practices. So we did that by looking at practices with a large 18 to 24 age group, to kind of come down to, with probably 40 practices working with large populations in the whole of the UK. Next stage of this, which is a paper that's just been done, is to actually then try and measure that against measures of quality. Because if you're going to work at scale, and if we're going to push practices to become bigger, to be broader, to things, then we need to know what's happening. There have always been these kind of networks in the UK, but it's getting more complicated. And again, that's an important issue if you want to do a quality performance framework, because instead of having all these nice individual GPs, which were then nice 7,700 practices in units, it's now a god almighty mess. And it's a mess that is constantly changing, which is now down to things about relationships between practices, relationships between GPs, the way that they work together. And we're trying really now to force them, and from June, every practice should be in a primary care network. They have to. When everything gets down to a have to, you certainly know something's going to go wrong. So practices are being forced into groups again. And practices tend to be fairly fiercely independent, for all kinds of reasons. And the idea is that we're going to use peer pressure to make things better. So networks will have 30 to 50,000 patients, but of course networks don't. There's lots that are under 30,000. So, if you fit the criteria of being in a very rural area or whatever, or they're over 50,000 if you're in a big conurbation area, because that's true, so then you have to subdivide. We've been through all this in the UK. Right through for the last 20 odd years, we've been playing with what's the right size. It's like a game. For some reason, 50,000 appears to be the right size, but nobody's really sure. In fact, we did a little piece of analysis for the government. My colleague, Kath Checkland, went back through. We couldn't find anywhere, apart from someone saying in a policy paper that 50,000 was the right practice. Well, that's good evidence. Anyway, so network agreement is the way that they're going to work. So the practice is going to join together, and they're going to have a single contract. Then the government, in their wisdom, said, and one practice will hold the contract. Okay, the lack of understanding sometimes in that kind of higher policy realm of what goes on at the ground level is unbelievable, really unbelievable. But it's not the only thing. We've got integrated care systems, which kind of sit over the practice networks. We've actually got clinical commission groups. Now that's interesting, because some of the same practices will be in the provider group, will also be the people that are in the commissioning group and in the integrated care. I mean, this is just messy. You know, where is the kind of continuity around accountability and governance and all these kinds of things in this kind of system? It is very, very messy. And the problem is, you know, actually we're not sure that big is better anyway. I mean, there's quite a few problems. There's no agreed definition of what we mean by integrated care or care coordination. You know, people with stronger primary care has better coordination, but, you know, we often leave out some of the younger ill people, which isn't so good. Integrated organisations may be better at care coordination, but in the 2017 UK patient survey, the big practices continuity went down, not up. Surprising? Not really, no. More people that are involved, some very good research. Once you get over 4 doctors and a team, the team starts to become dysfunctional. So, you know, kind of thinking about these things is really important. Problems of scale still. So patients registered with larger practices report worse satisfaction. Well, that's not a good thing, is it? Practice in England, fewer GPs had slightly higher rates of preventable admissions than larger ones, but the US data showed the opposite. Smaller practices in England had lower quality and outcome scores, but there was actually little evidence that larger practice groupings had the higher patient satisfaction and quality of prescribing. So really mixed evidence around this. What evidence there is, because actually we don't have a huge amount, but what evidence is incredibly mixed. And it may be that group practices are no better than single-handed GPs at delivering high-quality prescribing for diabetes. So how do you distill out of this kind of thing? One, your policy direction, but also what kind of performance framework you're going to impose if your performance framework is working towards this idea of scale and larger things. There are many different models, funding structures, and what constitutes to organise primary care, but we do know that diverse professional lay roles within teams tends to be better at support than just simply larger practices, so that's a bit of a positive thing. But the data about that mainly relates to small and large practices, not to groups. So if we think about networks and making networks work together, we have no evidence whatsoever. So anybody that does policy analysis knows that's no barrier to development. Okay? The fact we don't have evidence doesn't mean anything. It's about direction of travel. So the NHS England vision for the future, which you can talk to people in NHS England at about the middle management level. Once it gets above that, you can't really talk about these things because they are the thing. That's quite important, that there is this kind of strong directional issue. Now, whether that's Simon Stevens, who knows everything, but his team around him. And the 5-year forward view was written by 5 people. You know, I mean, these are very, very small kind of cliques that are kind of pushing through some of this. The system, the NHS is very good at absorbing it. It has to be because it gets it every year. So anyway, shared QoF indicators across the network. The network is jointly rewarded for the performance of all of the practices in the network. Proceeds are shared across the network. Network responsible for allocating between practices. There is some evidence to suggest that that might work. You know, if you look at some of the provider networks in the Netherlands, you know, which focus on trying to get kind of peer pressure to improve diabetes care and things, you know, the evidence is actually there. It's not totally kind of, but that's not practices. You know, practices, you know, are only really beginning to work, to understand about working together, even after 20 years. So, and most of the practices work on voluntary things together, not imposed things together. So that's a difference. The other thing I want to do is introduce shared saving schemes. Now, there is evidence to show that shared saving schemes do save money. I mean, even back in the 1990s, where GPs were told, oh, if you can save on your prescribing money, you can invest it in other areas of patient care. So not personal gain, but, you know, actually improving, and it works. And I think there's an example in British Columbia as well. I seem to remember talking to somebody a couple of years ago in BC, where again they brought loads of docs together and said, okay, you know, if you can change things and save money, you can do something else. And they did. So these are people who thought would never talk to each other. So, you know, there is some evidence to support that. But the thing is, they want to reduce A&E emissions. We're really absolutely kind of A&E emissions in the UK is the thing that everybody wants to reduce. Trouble is, if practices save A&E emissions and save money, they don't get the money. The commissioner gets the money, not the practices. So hang on, what's the incentive for practices? Oh, well, but they're part of the clinical commissioning group. But they don't, there isn't that personal incentive. So this has actually got to be thought through a lot more. You know, the problem is, and we are an easy system in the UK because the money only goes through one organisation. You know, you come to Canada where docs get paid one thing and the hospitals get paid another, LIN's got another bit of money. You know, you've got a split system. At least in the UK, we have a much more kind of streamlined finance structure from that point of view. But it's still going to be difficult about, you know, incentivising one organisation. We have this with public health. Local government does public health. If it can reduce the pressure on the NHS saves money, but it costs local government a heck of a lot of money. So what's the, you know, these are important. Money is important when it comes to these sorts of things. So a few reflections. Primary care is becoming a bit of a difficult, actually it's becoming more interesting. I mean, you know, let's face it, I'm a health services researcher interested in primary care. Great looking at general practice, much more interesting now because of all the change that's going on. And particularly because the change is being driven from different forces. And I think that's really interesting. But where should quality improvement be most focused and how should we do that? You know, what is it, how do we get some systems? Do we need to do it even? Who should define the quality improvement? Should we let NHS England set out the parameters at a kind of a high policy level? But, you know, perhaps they should set broad parameters. You know, and then not the actual activities, and then get people to actually do the activities. Now, there's been some of that done in New Zealand, where they've got groups of practices, which seems to work quite reasonably well. But there's still a question of, well, what's the measurement of it? You know, if you're going to hand over money as the government, what do you think you're getting for it? You know, that's quite important. I think this external versus internal determination is very important, this kind of extrinsic and intrinsic. Thinking about the drivers which drive practices, making sure that they get aligned. You know, I think it's really important. Can we get practices to actually start to articulate what it is that provides good, you know, get them to reflect on what is good quality care, and then start to build a system. And this big question, will peer pressure actually deliver higher quality care, or is it going to be more divisive in the system? You know, the idea that your neighbouring practice is peering, and I can tell you, I'm sure you know this, if you go and talk to the receptionist in a GP practice, and you say, which practices should, you know, would you go to? And apart from, they usually won't go to their own, which is fair enough, but they'll know which ones they do or don't want to go to in the local area. You know, that's quite interesting, and that's back to this kind of reputational and trying to work out what's going on locally in the system. Well, if that's true, and you put those people into a group and want to get them to work together, I think it starts to raise quite difficult questions overall. And we shouldn't forget Peter Smith, who's at Imperial now, a very sage economist, says practices develop performance measurement rarely pursued with a clear picture, and that's absolutely true for quality and outcomes framework. In fact, they now know what they think they wanted the quality and outcomes framework better than they did when they put the quality and outcomes framework into practice. Everybody had a different idea what it was about originally. But performance systems typically present a range of data, often chosen because you can collect it. You know, I mean, and that is true in a system as anything, and basically you hope that the information is going to be useful to somebody somewhere. But then we tend to design the system around what's available, and we shouldn't, I think it was Einstein who said, not everything that counts can be counted. So, thank you.